Okay, we're talking about pregnancy at risk, and this is pregestational problems, and this is just an introduction. Wow, we got a lot of people absent today, don't we? Okay. Oh, because of the test? Okay. When those of you who have had babies in here, when you found out and discovered that you were pregnant, what was your first response? Okay, that was good. So stop smoking. What else? Was it a planned pregnancy? Okay. What, Douglas? Every pregnancy in 2016 is planned. Well, I would probably agree with you. If you are sexually active and you're not taking steps to prevent pregnancy from occurring, then, yep, you are planning pregnancy, aren't you? Because you know what? Every time you have intercourse unprotected, then there could be a baby. Does that scare you? Okay. Do we normally think of pregnancy as being life-threatening? No, but can it? Yeah. Emily, were you afraid? When there were complications that occurred in your pregnancy, you were afraid for yourself and for your baby? Yeah. Okay. Anybody? Who else had complications? Megan, you did, and Miranda. What? Were you afraid? Yeah. Oh yeah. You had to take that long ambulance ride or what? Wow. Yeah, that was scary. Joya, you were afraid. Okay. Yeah, it's a scary kind of thing, and it's also when when you think about the responsibility of when you're in labor and this baby's real. Oh my gosh, it's going to come and I'm going to have it, and then what? It's overwhelming to some degree. So the second bullet says that a high-risk pregnancy, and this essentially is the definition, is one in which the life or health of the mother or fetus is jeopardized by a disorder coincidental with or unique to pregnancy. So what does it mean coincidental with? Like what? Okay, so let's say I'm diabetic. Is that coincidental with pregnancy? Okay, gestational diabetes would be unique to pregnancy, versus if I'm diabetic and I become pregnant, that's the first part of the definition. Does everybody see that? Or if I have asthma, that is coincidental with pregnancy, versus that's not unique to pregnancy, is it? Okay, so pregnancy-induced hypertension would be unique to pregnancy, versus if I were hypertensive prior to the pregnancy. Does that make sense to you as far as the difference in the definition? Okay. Now, for the mom, this high-risk definition extends through the first days post-delivery or postpartum. Important for you to remember. Whereas perinatal morbidity can continue for a lifetime. It might be a couple of weeks. Your child anybody's child in the neonatal intensive care unit for a short period of time? Emily and Miranda. How long? 7 days. How long? 2 weeks. Wow, big bucks going on there. But it's frightening that this is going on with your child. And why was your child in there, Emily? Okay. And Miranda? 35 weeks. He had how much for? Yeah, and he was with you when that happened, wasn't he?
No, I was at our house. He was there, and that was the day I decided I was tired and didn't want to break, and that happened. And he was my glowworm baby.
Okay. Yeah. Okay. Scary. But any residual? Okay. Because he was preterm and he was only 4 pounds, does he have a learning disability? Okay. Autism. This is your autistic child. Okay. So problem is that we don't know, and research can't tell us that there's any connection to any of that. So there's only speculation at this point in regard to that. And your other two children are no problems with the pregnancies. Okay. Catherine, any difficulties?
Yeah, he was in the NICU for about, I think it was 3 days. It was a long time, and it was, the placenta was calcified.
Okay. Any residual?
They think that he has bipolar.
Okay. Well, no, that I wouldn't think that would be residual. That would be genetic. Okay. Okay. All right. So when we think about the fact that, so Miranda's child, his is a lifetime. Brandon, did either one of your children have to go in? 2 days? For? This was a forceps delivery. Facial paralysis. Meconium. I don't know. I think everybody who has meconium amniotic fluid needs to have a C-section. Just get the baby out. And we know that they're... So, you know, I don't know. Did Ms. Murphy talk to y'all about amniocentesis? Okay. So, there's a difference between not having information about what's going on with your child. Okay, so I was a labor and delivery nurse, so I already knew that I was at risk, okay, high-risk pregnancy. And I wanted to make the decision to have all natural and go to a nurse midwife, but yet because I was a labor and delivery nurse, I kind of knew too much stuff, and I kind of needed to have a little more control over the happenings instead of it just being happenstance. And so took, you know, and I have spina bifida occulta, and so I wanted to make sure that my child didn't have any issues as far as spinal formation or neural tube defects. And so I had those level 3 ultrasounds pretty early in the pregnancy. And I don't know why I'm telling you this. Where was I going? Okay, so if we discover during the pregnancy that there's an issue with the fetus, okay, then choices can be either to terminate the pregnancy early on or to continue the pregnancy knowing that this child is going to be born. So the baby's born without a diaphragm intact. Okay, that baby's going to have immediate surgery, right? So, or may have to have surgery in utero. And versus knowing that this child, if your child has, say, spina bifida that's diagnosed on ultrasound, then they're going to know that this baby's got to be born by cesarean birth because that baby can't come through the birth canal because it may, for the potential of that child to exist, that I'm going to deliver that child by cesarean birth and then know that that child's going to have immediate surgery within the next probably 48 hours. But yet there's a team that's already set up there ready to go knowing that there are problems to begin with. So when I talk about this high-risk pregnancy, that's what I'm talking about in terms of if there's a pre-existing condition that is coincidental with the pregnancy that occurs, it was on board, then the pregnancy occurred, versus a condition that occurs uniquely to pregnancy, we still, is this a reason why people need to get prenatal care? Yes, it's free. It's free. All you have to do is show up, okay? And I don't know how to get that message across to people. Do you have any ideas about that?
I like your billboard.
The billboard, okay. You're growing baby brains, you know, go get checked out. Because if there is a pre-existing health condition, don't we need to diagnose that early so that we can any intervention that needs to occur to save your life or save the baby's life, that we can help you stay healthy and help you keep that baby healthy. Does that make sense to you? Maybe it just makes sense to me. Okay. Why do you think that it seems like we're having more risk factors impacting pregnancy? When you were over in labor and delivery, those of you who've already been and postpartum, did you think that there were a lot of women who didn't have a normal pregnancy event? Or did you think they did have a normal pregnancy event? Yours did? Anybody else have a thought on that? No? Okay, so I'm thinking it's a little bit of a perceived kind of a thing. But when when I talked yesterday about the fact that we're concerned about the quality of life versus the quantity of life, yes? So we have moms who have had multiple pregnancy losses, and they're coming in to have this baby, and they're in preterm labor, but they've suffered multiple pregnancy losses, and so are they fearful for another pregnancy loss? Okay, and so they're not going to be concerned about what it's going to cost that baby to stay in that NICU for weeks or months, because they need a child that's going to survive. Does that make sense to you? And so they want you to, no holds barred, do everything that you can medically possible to save my baby. Okay. And I think that the assumption that, you know, if you get pregnant, you're going to have a normal, healthy baby is what happens the majority of times, don't you think? Okay. And so until there is something that indicates to us that there is a problem, then we're more fearful. So the next slide talks about the leading causes of maternal death. So number one is those hypertensive disorders associated with pregnancy. So pregnancy-induced hypertension is number one cause of maternal death. The complications associated with the outcomes of that. This isn't all in your book, okay, so it's on your slides. Then the second is pulmonary embolism. Now, why would a pregnant woman have a pulmonary embolism? Hormonal changes associated with the clotting factors that occurs during pregnancy, right? Sorry, I've got some kind of something in my head. Yesterday, I couldn't breathe through the right side of my sinuses or nose, and now it's just full all over. Okay, so pulmonary embolism. So can you have a pulmonary embolism anytime and like die? Okay. And then the third main reason or cause of maternal death is hemorrhage. Hemorrhage. So Ms. Murphy stressed to you and Ms. Coker stressed to you how important it is for you to assess that uterus to make sure that it is. So if you find the uterus not firm, then what is your first action, nurse? Massage the fundus. Okay, good. And then other causes include complications associated with cardiac and other medical conditions like diabetes and infection. Okay, and so this is maternal. Then the leading causes of neonatal death includes congenital anomalies, number one. Then disorders relating to short gestation. What's another term for that? Preterm birth, okay, and low birth weight babies. What causes low birth weight babies? Okay, smoking. What else? What? Young mothers, so adolescents, early adolescents. Okay, what else? Alcohol, poor maternal nutrition. What, Hannah? How does that happen? Yeah. Fetal growth retardation, fetal growth restriction, okay, can be associated with diabetes during pregnancy. Respiratory distress syndrome. Why do you think babies would get that? Preterm births, okay. What'd you say, Emily? Yeah, meconium aspiration. The amniotic fluid is essentially the same pH as what's going on with the baby. And as I've said to you before, the baby breathes and swallows the amniotic fluid, urinates into the amniotic fluid, but there shouldn't be a bowel movement unless that baby experiences a severe hypoxic event like strangulation of the umbilical cord, or if the mom has a respiratory or cardiac condition that can alter that blood flow to the uterus, can that also put that baby in a hypoxic position? Okay. Sudden infant death. Are we hearing much about that anymore? Not as much as used to. Why? Back to sleep. Put the baby on back to sleep. Okay. But I have a young woman in this community who has just had her second child. Her first child died around a year, maybe a little bit more than a year. Sudden infant death, and they had a baby monitor, and I mean she put him to sleep, and he wasn't okay when she went to get him. Just one of those things that happens. We don't understand exactly. And then the effects of maternal complications on that fetus. Okay, so you have a handout, categories of high risk. Gave it out yesterday. Does everyone have that? So am I correct in assuming that these handouts up here are Janet's? Or did somebody get Janet's? Mackenzie, you don't have these? Do you have either one of them? Did Janet get hers yesterday off the desk? Does anybody know? She came by, but anyway, okay. All right, when we look at categories of high risk, the first one is biophysical factors. So genetic considerations. Why do we need to be concerned about genetic considerations? Do we want the pregnancy to start out well? Do you know that there's a family history of certain genetically predisposed conditions in your family? Okay, so I had an aunt who had a child, and I don't think she was autistic, but I think that she was probably some degree of high-level functioning Down syndrome. And so, again, I was concerned because that was my mother's sister, and so was there something genetic that could be transmitted? And, of course, I knew about the spina bifida occulta, but do we know about cystic fibrosis if you're a carrier? Do you know if you're a carrier of other inborn metabolic disorders? Do you know if there's a family history before you get pregnant, before you have sex and make a baby? What, Joya? Not always, okay. What about the father's family history? Do you know what that is? Okay, so, there's some things that you need to take into consideration as far as genetics are concerned. Because babies can be born with congenital anomalies associated with genetic defects. What about your RH type? Could cause ABO incompatibilities or RH incompatibilities. So if you're RH negative and your husband's RH positive and you got an RH positive baby, could that be a problem? Okay, so do you know what your significant other's RH is or what your RH is? For the most part, okay. Nutritional status, I've talked about nutrition already. So is nutrition important during pregnancy? Yeah, because you're what? Growing baby brains, thank you. Medical and obstetric disorders, complications of this pregnancy as well as past pregnancies, any obstetric-related illnesses, and pregnancy losses. All those put your patient at higher risk categories. Psychosocial factors, we talked about smoking, increased caffeine in your diet. Some babies are very, very sensitive to amounts of caffeine that you consume. Where is caffeine? Where are hidden sources of caffeine that we don't even think about? Chocolate. Okay, so poor Katie Barnes, she had an overdose of peanut M&Ms in the last trimester. Because students were selling peanut M&Ms and the boxes were in my office and they were 50 cents a box, and so I just throw $1 in and eat 2 boxes. But again, some babies are very, very sensitive to that. Now, I didn't drink Diet Coke or any of that kind of stuff, or Coca-Cola, or but I ate the chocolate. Alcohol. What about alcohol? How much is okay to consume during pregnancy? None. My niece had a baby in December, and her doctor told her that she could have a little bit of wine every now and then. And when she told me that, I didn't hold my face still. And I said, well, that's nice that your doctor told you that. I said, but there's been research studies shown that we don't know how much alcohol is too much that can cause your baby to have issues. So anyway, and cigarette smoking, she was a big smoker, and she had started using the e-cigarettes, and then she stopped toward the end of the pregnancy. Well, she was breastfeeding to begin with, and then her husband's a smoker too. So what do you think has happened now? Yeah, everybody's smoking. And, and I said to her when she was in the hospital, I said, because his side of the family smokes a lot and her side of the family smokes some. I told her about second and third hand smoke. So if it's in your car, if it's on your clothes and that baby's being held up against somebody and their face is against your clothes, what are they breathing? Cigarette smoke. They are a prisoner. They can't escape from that. So they're inhaling all that. So anyway, had those conversations. Don't know that it did any good. Drugs, what kind of drugs? Anything can be teratogenic, can it? We just don't know how much and to what extent. Can cause metabolic disturbances, produce chemical effects or depression or alteration of central nervous system function. Medications prescribed by a healthcare provider or if you bought it over the counter. I'm going to also include herbal medicine in this drug. So what about herbal medicine in pregnancy? They're not FDA approved, but what is the other concern associated with pregnant? What? Okay, some of them are abortifacient, have abortifacient fat characteristics. What else? You don't know the amount you're consuming. So you could be consuming toxic amounts, and if they go into your baby, can they get out? No, they're just going to continue to recirculate in there, okay? And then, of course, those street drugs, heroin, cocaine, marijuana. Problem during pregnancy? So babies can be born addicted? So the bad thing if you have a cocaine baby or a heroin baby and they go home with the mom, even if that mom and that baby are supposedly in a safe setting, if the mom is stressed and the baby is crying and stressed, okay, Heidi said shaking baby. Well, my concern would be that she'd give that baby a hit of the heroin or the cocaine, whatever it is, to calm them down. Joya? How, 34 years old. How come she was tested?
She didn't have prenatal care, right? She didn't have any prenatal care, I think. No prenatal care.
That sets you up for a whole long line of testing and sets you up for immediate social service consult, and that's a red flag. 34 weeks.
My little brother was born he's adopted.
Oh, yeah, okay. So I was thinking, I know your parents. I mean, I'm thinking, okay. So Heather said that her little brother was born addicted, and he's adopted. So he was he was.
I would rock him and he would cry and I would cry.
Yeah. Oh, how old were you?
He's 4. So
No, how old were you when you got him?
he's 4.
So you're talking about holding him and rocking him and you crying and he crying and he was 4?
No, he's 4 now. When he was a baby, we got him at birth.
Okay. Sorry, that was where I was going with that. I wasn't sure. Okay. But how old were you? 21 when he was born. Okay. It's of grave concern, and it's going to continue to be. And you have methamphetamine addicts out there that are going to come into the hospital and have babies, and it's scary. So say that louder, Heidi.
We had our behavioral health holding unit about 2 weekends ago. We had a woman who was 36 weeks pregnant, 34 years old. This was her 3rd pregnancy, and she was coming off, remember, it was heroin, cocaine, and she was acutely psychotic. So we were having to be very careful of what we could give her. Like, we were trying to do everything, but not. I think we eventually had to give her 1 shot of Haldol, and that was a last resort.
It's scary. It's scary. And then there are wonderful people in the world like Heather's family, and some of you may also know of other families who have adopted those babies that were crack babies or heroin babies or otherwise addicted babies. And they have neurobehavioral problems. Okay. Psychologic status. Well, this first sentence says, childbearing triggers profound and complex physiologic, psychological, and social changes with evidence to suggest a relationship between emotional distress and birth complications. Does that make sense to you? So if you're emotionally unstable prior to a pregnancy, and then you add the pregnancy, what kind of a crisis is pregnancy? A situational crisis versus if you have a psych diagnosis prior to the pregnancy, then yeah, it's situational. then is that, what kind of crisis is that? Oh, sorry, I got that wrong. So maturational crisis is pregnancy. Situational crisis is, okay. I wondered why y'all were looking at me so strangely. So pregnancy is a maturational crisis. Family's growing, family's changing. Versus a situational crisis when you have, you know, you can be stable, but because of the hormones of pregnancy can make you a little unstable during the pregnancy, so can that present problems? Okay. So sociodemographic factors, of course, low income. What's the main thing about low income? What's the problem? Okay, education. What else? Nutrition. Nutrition. What do moms need to have a lot of? Glucose. I mean, not glucose. Protein. 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 They need protein. Fruits and vegetables. Okay. And then number 2 says lack of prenatal care. Again, if we start prenatal care early, you get the baselines done. They follow you and manage you and monitor you for any potential complications. Age. What about age? We have adolescents and mature mothers. Well, I was called, oh shoot, an elderly prima gravida. I was 33 years old when I had Katie. Elderly prima gravida. So, but when we look at what's the earliest age that you know of someone having had a baby? 10? Somebody knows really somebody who was 10 years old?
I saw a news article saying that the world's youngest grandma was 22 and her daughter had her first baby at 10 years old.
13-year-old and a father was 14. It's so sad to me. It's so sad to me. Is that culturally okay? In some places it is. So in some places that's right. Once you begin menstruating, you're married off because your job is to what? As a female, yeah, make babies. Tragic. So women at either end of the spectrum, and I know Ms. Bishop talked about that, have a tendency to experience more complications. So a younger person would be because their body's not mature. They're also at greater risk for those complications unique to pregnancy, okay, like pregnancy-induced hypertension, like I talked about preeclampsia and eclampsia yesterday. So if you're 12 years old, you're at higher risk. Versus if you're 35 and older, you're at higher risk. But also, the higher your chronological age, what else, bless you? What else? What? Old eggs, did somebody say that? Okay, not old eggs, bless you. But there might be other comorbidities going on with my body. Okay, so I might have some renal compromise, or I might have some respiratory compromise, or I might have diabetes, okay? All right. Parity, what is that? Okay, this says that a first pregnancy at either age of the childbearing continuum, the incidence of, bless you, PIH and dystocia. Oh, I lost my place. With the first birth, okay. Especially that young child, that young girl, so higher risk of cesarean birth. Marital status, well, if you're married, you have decreased risk of morbidity and mortality. Residence. If you live in a metropolitan area, chances are that you'll have increased prenatal visits versus if you live in a rural area. Why is that? Access to care. Okay, and ethnicity. Says African American babies have the highest rates of prematurity and low birth weight, with the infant mortality rate being more than double that for white. Environmental factors. I didn't create this handout. Fertility can affect fertility and fetal development, the chance of a live birth, the child's subsequent mental and physical development. Environmental influences such as infections, radiation, chemicals such as pesticides, Therapeutic drugs, illicit drugs, industrial pollutants, cigarette smoke, stress and diet. Paternal exposure to mutagenic agents in the workplace are also associated with increased risk of spontaneous abortion. And what else? What else can cause you to have dysmorphic sperm? No. That decreases the amount of sperm, not causes them to be dysmorphic. Marijuana. I didn't hear it. I'm sorry. High doses of, high use of marijuana. I mean, it's funny. I look at people on TV and I'll look and see what kind of breasts they have. Men breasts. Okay. All right. On the back page, it talks about specific pregnancy problems and related risk factors. The number one is preterm labor. Age, less than 16 or greater than 35, higher risk. Low socioeconomic status. Maternal weight below 110 pounds. Who's that going to be? You think that's going to be your 35-year-old? Maybe. Yeah, so it could be anorexia or bulimia that's going on. Could be drugs. So other of concern. Poor nutrition, previous preterm birth, incompetent cervix. So those would be pregnancy losses. Uterine anomalies, cigarette smoking, drug addiction, alcohol abuse, pyelonephritis, pneumonia, multiple gestation, anemia. Anemia compounds pregnancy. Placental abnormalities and infection. Polyhydramnios can be associated with diabetes, mellitus, multiple gestation. Of course, that makes sense. Fetal congenital anomalies, isoimmunization, non-immune high drops, and abnormal fetal presentation. Intrauterine growth restriction associated with multiple gestation could be poor nutrition, cyanotic heart disease in the mom. We're going to talk about that in just a minute. Chronic hypertension in the mom. Why? What happens? What's decreased? What's altered? Blood flow to the placenta. Good. Pregnancy-induced hypertension. Recurrent antepartum hemorrhage. What causes that? Could be a placenta previa or low-lying placenta. Again, smoking, diabetes and vascular problems, fetal infection, fetal cardiovascular anomalies, drug addiction, alcohol abuse, fetal congenital anomalies, and hemoglobinopathies. Oligohydramnios, renal agenesis, number one. Prolonged ruptured membranes. Do you always know when your membrane's ruptured? Those of you who've been pregnant? No. Intrauterine growth restriction, intrauterine fetal death. And then post-term pregnancy, anencephaly. Placental sulfatase deficiency, it's an inborn error in metabolism where estrogen is not synthesized appropriately. Perinatal hypoxia or acidosis, placental insufficiency. Chromosomal abnormalities, of course, the greater the age of the mother and the father, the greater the risk of there being congenital anomalies associated with chromosomal abnormalities. Factors that place the postpartum woman and neonate at risk. The mother, if she's experienced hemorrhage or infection, abnormal vital signs such as hypertension, a traumatic labor or birth, and psychosocial factors. Anemia is another, along with that hemorrhage that can contribute to risk factors for the mom. So if her hemoglobin is less than 10, is that a problem? Is she going to feel like taking care of that baby? The infant admission to NICU, continue with or develop signs of respiratory distress or other respiratory distress. Asphyxiated infants, an APGAR score of less than 6 at 5 minutes. Anybody have one of those? All your babies were good? 8, 9, 9, 10? Preterm infants, dysmature infants, infants with cyanosis or suspected cardiac disease, persistent cyanosis. Did y'all have any babies born with heart disease? Congenital anomalies? Major congenital malformations requiring surgery, convulsions, sepsis, hemorrhagic diathesis or shock, meconium aspiration syndrome. I think you told me one person had meconium stained amniotic fluid. Central nervous system depression for greater than 24 hours. Hypoglycemia, hypocalcemia, hyperbilirubinemia. Not necessarily. Some of those can be associated with the other risk factors. Moderate risks, dysmaturity, prematurity, APGAR score less than 5 at 1 minute, feeding problems. What's something that you clue into if you think of a baby who has feeding problems? What might be affected? Yeah, because they have the desire to eat, but they tire out in the middle, and they have perspiration on their heads, so they're a little bit of failure to thrive. Transient tachypnea, failure to gain weight, jittery or hyperactive. What might that indicate? Drugs, cardiac anomalies, heart murmurs, anemias in the baby, and central nervous system depression for less than 24 hours can increase the risks. So, of concern for those moms and those babies. Okay. Uh-huh.
The first pregnancy was fine, no issues. Second pregnancy was fine, no issues. She worked at the UNC in the children's department. She was 36 weeks pregnant, not had any issues. Suddenly became preeclamptic, and the pain went like fell off. Went to the doctor. By the time she got to the doctor, went into the C-room, had her on the table, she threw the box out.
Oh my gosh, Judy. 28? Oh my goodness. Well, so they were resuscitating her, trying to get her to C-section to deliver, or?
Yeah, they took her back with the C-section. When she came in, and she fell off, and they got her blood pressure, and they were like, he's got to come out. But then, while she was on the table, taking him out.
Wonder if she didn't have an amniotic embolism. Because very few women survive that, but not good. Wow. Thanks for sharing that.
Whenever she delivered her first two babies, her placenta and the umbilical cord had disintegrated inside, and so they were both born preterm, one at 36 weeks, one at 34, but they didn't find it out until she started carrying her third child. But it wasn't anything wrong, like it was her disorder, but it didn't affect her, it affected her pregnancies. So now she has two programs. That was the defective 1298.
Oh, yeah. Wow. Okay.
So she's had this now, but she wasn't the first two.
Okay. How far along is this pregnancy?
Well, she's already delivered.
Oh, okay.
But she
Okay.
didn't feel
Okay. So this slide talks about when pre-existing chronic conditions, she and the pregnancy are at high risk. So that's one that's coexistent with the pregnancy. And the course of normal pregnancy can complicate the disease, and the disease can cause complications that affect the fetus or leave the mom feeling less equipped to function as a mom and possibly undergo a future pregnancy. So there's a couple more things that I need to tell you in regard to this that's not on the slides. So in order to help avert some of these complications associated with pregnancy, what needs to happen? Okay, first they need to come in to be assessed, right? So when you think you're pregnant, how long do you wait before you go see the doctor? 8 weeks? Okay, it might depend. So if it's a subsequent pregnancy and they know that you're already high risk, they may have you come in sooner. But are they going to intervene to maintain a pregnancy during the first 8 weeks? No. Okay. So that accurate prenatal assessment, how long was that form y'all had to fill out? And do you think somebody really looked at all that 10-page form to see what they just looked down and see where you said yes or no on the answers? So moms need to know signs and symptoms of illness that need to be reported to the healthcare provider in terms of that pregnancy and how it could affect that, right? So if I have cardiac disease or diabetes, what do I need to know about to let my healthcare provider know if I'm pregnant that could possibly cause further complications for the pregnancy? Did y'all eat breakfast? I don't know. It's okay. So if I have cardiac disease, what would be some symptoms of complications? Edema. What else? How would I know dysrhythmias? Okay, what's that called? Palpitations. What else? Put your thinking brains on. What kind? Hard to catch your breath, shortness of breath. What's a very subtle, quick, early sign? Cough. Cough. Cough is the answer. It's on your test. Cough. Congestive heart failure with your cardiac patient. Congestive heart failure, pulmonary edema, increased fatigue. So what are some assessment techniques that we're going to use to assess this mom to find out if she's okay and this baby's okay? EKG on the mom. Okay, so we might do a external fetal monitor on the baby to monitor her during the pregnancy. Is she going to be monitored more closely? Okay. Routine blood work, routine urinalysis. Yes. Okay. We need to talk to her about her daily activity and how she's feeling throughout the day, and we need to give her a handout about how to evaluate how she's feeling and when danger signs when she would need to notify the healthcare provider that she would be at risk. Do you think it's hard being a nurse if you're dealing with and helping and assisting women who have complicated pregnancies through this process? Do you think you need to be more supportive and encouraging? Okay. All right. Any questions about this? Okay.